Hi everyone, our subject today is postoperative fever in pediatrics. Basics. Postoperative fever is defined as temperature greater than 38 Celsius on 2 consecutive postoperative days or 39 Celsius on any postoperative day. Fever during the postoperative period is common, occurring in 25 to 50% of cases. The magnitude of fever is correlated with the extent of the surgery. Minor surgery is rarely associated with fever. Early postoperative fever within 48 hours postoperatively is often caused by the trauma of the surgery. Infection is the cause of fever in about 10 to 25% of febrile postoperative patients, usually occurring after 48 hours. Fever usually lasts longer than 2 days unless treated with antibiotics, tend to be higher than 39 Celsius and is associated with ill appearance. Possible diagnosis in infant: common causes: dehydration, high ambient temperature, septicemia, intravenous line infection, hematoma. Rare causes in infant: infectious diarrhea, UTI, osteomyelitis, and pulmonary atelectasis. Common causes in children: dehydration, wound infection, transfusion or drug reaction, hematoma, and pneumonia. Rare causes in children: UTI and bacteremia. Simple differentiation between the common causes of postoperative fever. In dehydration, the fever on the one day of surgery, ill appearance. Wound infection, there is possible high fever with the possible ill appearance, and there will be diagnosis by seeing surgical site and leukocytosis high and reactive protein elevated. Transfusion or drug reaction, there is fever on day 1 of surgery with the possible ill appearance and leukocytosis with the elevated C-reactive protein. In hematoma, there will be diagnosis by seeing surgical site and possible leukocytosis and high C-reactive protein. In pneumonia, high fever with the ill appearance and elevated leukocytosis and C-reactive protein. Recommended investigation: urine culture, complete blood count, liver function test, blood culture, chest x-ray, viral study, occasionally requested if the fever persists. CT scan and or ultrasonography sometimes required for the detecting intra-abdominal abscesses. Top tips: physical examination should focus on site most likely to be the cause of fever, including the operative site, abdomen for distension, tenderness, absence of bowel sound, and the upper respiratory tract for infection and lung auscultation. The diagnosis of non-infectious causes should only be considered after excluding infectious causes. Factors that increase the likelihood of infection include long post-operative stay in hospital, fever commencing on the 3rd post-operative day or later, and fever over 39 Celsius that persists or has a hectic pattern, and the presence of intravascular catheter, the prolonged use of nasogastric or endotracheal tube, indwelling urinary catheter or shunt. Red flag: be aware that serious infection may exist in the absence of fever. This is usually in the case during the neonatal period and immune-suppressed children. The importance of postoperative fever exists in the possibility of infection, which can lead to death if not properly treated. Although most postoperative fever are non-infectious, patients should be treated with antibiotics if they appear unwell, the source of the fever is obscure, or there is leukocytosis with the high C-reactive protein. Before embarking on performing tests for postoperative fever, remember that the most common source of infectious fever is wound infection.